Okay. So let me see the chat questions. All good. Vanita, I'm going to ask you to mute if you can, just because you're echoing there. And I have some questions that folks sent. And I'm going to start with the second one, because the first one I actually think we might have answered last week. And Dr. Tin, and this is going to come to you, but the first question is there a safe hormone replacement therapy, experienced for 10 years, all of the perimenopausal symptoms, going into the third month without a period, if I have tested at a high risk for breast cancer with a mutated ATM gene? So Dr. Tannen, is that one I can have you respond to? I'm going to go on mute here.
Sorry. Can you actually repeat it? I was walking and didn't get all the details.
Yeah, the question is there a safe hormone replacement therapy for a person who is at high risk of breast cancer based on their genetics with a mutated ATM gene? They're currently going into their third month without a period and have been experiencing perimenopausal symptoms, it sounds like, for about 10 years.
Got it. So yes, I mean, classically you're in the perimenopausal period. And when you've missed 3 consecutive periods in a row, high likelihood that menopause is just around the corner. The good thing is that my conjugated estradiol is, does not increase your risk of breast cancer. I think that's a lot of kind of misinformation or a misconception that estrogen is a culprit in increasing your breast cancer risk. And actually the data shows that estradiol reduces breast cancer risk, and even in people with who are breast cancer survivors have actually reduced their recurrence risk. The progesterone, the synthetic progesterone that they use in the Women's Health Initiative, which was the study that showed a correlation between medroxyprogesterone and breast cancer risk, we don't use that kind of progesterone anymore. We use what's called micronized progesterone, and that too has quite good safety data and a good safety profile. So typically, even in people who may have a strong family history of breast cancer or like a genetic mutation, we use micronized progesterone as well as the estradiol, and just recommend that you do your regular surveillance, what you would do anyways for screening mammography or ultrasounds, whatever your doctor recommends. But we don't find that using these bioidentical hormones increases the chances for developing breast cancer. So you are definitely still a candidate for using the hormone therapy. Of course, we'd have to individualize it, do your blood work, see what you need right now compared to when you're fully in menopause, and then find the right kind of regimen for you.
Great. Dr. Tannen, I'm going to pass on another question to you. And if you think you're getting a echo, maybe go on mute for 1 second. But the next question is HRT related as well. And the question is, first, a sort of case story. I've been taking low-dose hormone replacement therapy for most of the last 20 years, a combination of estradiol, 0.5 milligrams, and norethindrone, a synthetic version of progesterone, 0.1 milligram, 1/2 tablet per day. This has been under the supervision of my longtime gynecologist, who recently retired and coincidentally referred me to the Jumpstart program a little over a year ago. I am now seeing a new gynecologist who has strongly recommended that I wean myself off the hormone replacement therapy regimen. I'm not so sure about this. When I've tried quitting before, the symptoms come roaring back, especially hot flashes and night sweats. And the last comment is, I hope you can comment on this and more generally address the pros and cons of hormone replacement therapy for someone my age.
Okay, great question. We used to think that hot
Dr.
flashes.
Tannen, make sure you're unmuted, just in case.
Thank you. Can you hear me? Oh, it's saying I'm unmuted. Can someone let me know if they can hear me? Let's see. Okay, yeah, okay. Uh, Thank you. So we used to think that hot flashes and night sweats may resolve after just a few years after the onset of menopause. But more and more data, especially since women are living longer, the data now suggests that for a majority of women, hot flashes and night sweats actually persist for anywhere from 10 to 20 years beyond the onset of menopause. So it's not super surprising that every time you've tried to wean off the hormones, these symptoms come back. So I definitely would not agree that you should get off the hormone therapy. What I would say though is that the progesterone, the synthetic one, that one I would change to the natural micronized progesterone. It was the synthetic one that I just was alluding to prior to the prior question. It was the synthetic one that had the increased risk of breast cancer in the Women's Health Initiative. So really, we've come away from using that, and we really opt to use the bioidentical micronized progesterone, which has not shown that breast cancer risk. Um, it feels very physiologic. Women have great response to it in terms of sleep, mood, hot flashes, night sweats, all of the cognitive benefits, the mood benefits. There's also medical risks that you end up mitigating when you stay on hormone therapy. You reduce your risk of heart disease, stroke, osteoporosis. Because you maintain good metabolism with hormones, you minimize your risk for cardiovascular disease, diabetes, high blood pressure, high cholesterol. So we really recommend that women stay on hormones as long as possible because of all of these benefits.
Yeah, I'll just add one comment. For those of you who might not have seen them, Dr. Tannen's been doing a series on bioidentical hormone replacement therapy for the Thursday webinar, health webinar series. And some of these subjects are addressed topically. The first one was on thyroid replacement. The second one's on testosterone replacement for men. And the last one on menopause. Did I miss any there? Or I think those were the three I'm thinking of. And I think there's another one in 2 weeks, if I'm not mistaken.
Correct.
Which I think is on testosterone replacement for women, possibly.
No, actually, we're going to talk about the actual hormone therapy for menopause
Got it.
and to discuss a little bit about the new data
That's
and
great.
safety.
Well, they've been wonderful presentations and educational topics. And for anyone interested in taking a deeper dive on any of those specifics, I would highly recommend them. And they should be available to all of you on the member portal. So anyways, just quick thought there. By the way, remember you can ask questions on the Q&A tab at the bottom of your screen, if so desired. The next question, it looks like is less of a question as a comment, which I'm assuming is actually a question, which is, at least as I'm reading it, says stress eating exclamation point, which I think is a great question as a statement. What I might say is there's a few things. Yes, there are physiologic reasons that people stress eat. And there are also some nutrients that I think make stress eating sort of cascade in a way that's, as one person said, kind of like pouring gasoline on a fire. And that is that sometimes certain carbs, and the more refined, generally the worse, the more they beget cravings for more carbs. That said, if really the source of the eating is actually stress, I think ultimately one would have to address the root cause of that stress, at least in part, to try to properly address stress eating itself. And so what techniques could potentially work? Things that have been shown to reduce people's stress levels in the past range from meditation to regular exercise to sleep. I would add to that potentially hormone optimization, just in a way that can improve people's anxiety levels, help them sleep, help improve mood. There can also be pharmacologic ways to help reduce stress or anxiety, some of which can also cause weight gain, so you kind of got to be careful. But certain medications can also certainly address anxiety actually quite well today. And then there's other strategies around, cognitive behavioral techniques, such as I think we referenced a few webinars ago in the Beck Diet book. where Judy Beck's daughters created a book specifically designed to weight loss that does try and use CBT or cognitive behavioral therapy techniques to help people manage stress more effectively. So in the end, I think that's one of those potentially complicated topics that's probably best addressed on an individualized basis with your clinician or with a health coach with whom you feel like you have a good relationship, to help try and understand, well, shoot, what is the root cause of your stress? And from that, what interventions might be beneficial to help you reduce that. If I forgot regular exercise, that's another great example of something that can significantly reduce stress and anxiety, to the tune of, 37 minutes a day was shown in at least one study to be the equivalent to taking an SSRI medication in terms of reducing stress and rates of depression or anxiety and rates of depression. So hopefully that is at least a partial answer to that question. I do think that one's probably best addressed on an individualized basis with your health coach, or as just one option, health coach or clinician. So there's another question that was at the top here that I kind of think we addressed last week, but I'm going to respond anyways in case we didn't. And plus, I think it's actually just a super important question. And this was that I would love to learn more about insulin resistance and how it's determined that one is insulin resistant, i.e. with difficulty lowering blood glucose with blood tests. And I do think we did respond to that last week, but the short answer is, when people don't think of insulin resistance as a diagnosis, but really if you look at all these different common diseases in the country, and those diseases are in the following kind of categories: PCOS or polycystic ovarian syndrome, prediabetes, type 2 diabetes, fatty liver disease, non-alcoholic fatty liver disease. These are all super, super common problems. And even more so as you get more and more diagnoses amongst that group. Those are all ultimately insulin resistant syndromes, with insulin resistance at the core of all of them. And when we think of insulin resistance, we think of a few things that's relevant. One, we think that subgroup is someone who tends to be more carb sensitive and needs to reduce carbohydrate, and particularly refined carbohydrates, in their diet to try to reverse that insulin dysfunction in their system. Two is weight loss can actually help that quite a bit. And three, in terms of the question, which was really, how do you diagnose this? Yes, it's a combination of blood tests, standard cholesterol panel, looking for your triglycerides and your HDL and that ratio specifically, your fasting blood glucose, your liver tests as other signs of early signs of fatty liver disease, and then something called your hemoglobin A1C. If you want to get even fancier, you can also do testing with what they call advanced lipid testing, or also known as advanced lipid fractionation testing. We're actually going to be talking about that test specifically on the health webinar this Thursday with Dr. Krause. But that's something that can show metabolic imbalances in the form of high concentrations of small, dense, low density lipoprotein particles, or LDL particles, that predict the proclivity to develop diabetes even before you have rises in insulin that are kind of implied within the insulin resistant syndrome. When insulin stops working, it starts to go up in your circulation. From a jumpstart point of view, that's problematic because that elevation in insulin tends to drive people to gain weight and store fat. And it's also associated again with a whole host of things that's dangerous for people metabolically: elevation in triglycerides, dropping of their HDL, elevation of their blood sugar, conversion of LDL particles from more benign large particles to smaller, dense, more what they call atherogenic or disease-forming particles. So anyhow, that's a subject near and dear to our heart at Jumpstart, in part because a low-carb diet, whole food-based diet, particularly when combined with weight loss, is so darn effective at reversing that insulin resistance and promoting insulin sensitivity. And because insulin resistance is such a common epidemic ultimately in our country today, that's associated with increased risk of heart attacks and strokes and formation of diabetes and cancer risk, among other things, we think it's something that's super important, and something that we are constantly trying to do in terms of trying to prevent these downstream health risks and improve people's metabolic health and balance. So any other questions today before we apologize again for being late as a result of this very unusual sunny day power outage? It was just so strange. Looks like, let's say no. But thank you. We'll see you again next week. We hope we'll be on time. We'll be in a place where we have power. And I hope that was all clear. And thank you for joining us today.
Thank you.
Bye.